And welcome everybody. Before I introduce Dr. Finger, I would like to read our land acknowledgement. The Alzheimer's Society of Huron County gratefully acknowledges that the geographic area that we support is located on the traditional lands of the Ojibwa, Chippewa of the Anishinaabe, as well as the Haudenosaunee and Neutral people. Huron County is on territory that is covered by Crown Treaty Number 29, which is also known as the Huron Tract Purchase of 1827. We recognize and deeply appreciate the historic and ongoing Indigenous connection to this place. And as a community, we have the responsibility for the stewardship of the land on which we live and we work. Our role as treaty people as we work together to peaceably share and care for the resources around our Great Lakes. We commit to our ongoing learning and the journey towards reconciliation. So just a few housekeeping items. We will be going through the presentation with Dr. Finger. We will have time for questions at the end. I already have one question that was sent in, and I'm sure there will be more. We have the chat enabled so that when you send us a question, the panelists will be able to see it as well as Dr. Finger. But other than that, it will be anonymous. We do have closed captioning enabled. At the bottom of your screens, the participant screens, you should see what says live transcript. If you would like to see closed captioning, you can click live transcript and you should have the option to see your subtitles there. I have Kathy Ritzma has joined us. She is the Executive Director for the Alzheimer's Society of Huron County. I am Jeanette Sears. I'm the Public Education Coordinator for the Alzheimer's Society. I have two of my coworkers also on here helping us in case we have some people with some connection issues. But I am very happy to introduce our speaker this year. Our guest speaker is Dr. Elizabeth Finger. She is an Associate Professor of Neurology at Western University. She is a neurologist at the Parkwood Institute and a scientist at Lawson Health Research Institute. In addition to many other ongoing research programs, she's very busy. Her recent research has also focused on empathy in patients with frontotemporal dementia. And I believe she's also a board member at the Alzheimer's Society of London Middlesex. For tonight's presentation, Dr. Finger will be presenting some of the latest research and theories concerning inflammation in the brain and implications for dementia. I know at the Alzheimer's Society, as we're out and about working with clients, working in the community, we often get lots of questions about inflammation, about questions about the connections between chronic inflammation, dementia. So we are certainly looking forward to hearing Dr. Finger and learning what she has to say. So welcome, Dr. Finger.
Thank you very much, Jeanette, for that very kind introduction and for the invitation to speak to the group tonight. And if you don't know already, you will probably realize soon, anyone doing research typically is happy to talk your ear off about it. So, so I appreciate the invitation. We did decide today to focus, as Jeanette mentioned, on inflammation and dementia. And so this is an area that, of course, I think is of interest to all of us, or ought to be. It's an area that I'm interested in very much clinically because it has a lot of implications for how we approach the clinical care of patients, or at least we wonder if it does. And in terms of research, it's an area that I am a bit newer to, but I'm involved in some studies that I'll tell you a little bit about as we go. And certainly I think this is a huge growth area in the future. You can see my slides okay there?
Yes, they look good.
Okay, wonderful. So I'll just give my disclosures, which is kind of pro forma these days. And I will say I am involved in some scientific advisory boards for some biotech and pharma companies who are increasingly exploring the space around neuroinflammation and treatments targeting it in some of the dementias. But I don't have any personal stake in any products or kinds of imaging sequences, etc. So I thought we'll start a bit broadly, just because we may be coming to this with kind of different levels of knowledge depending on our role and our stage in the journey of contact with dementia or experience of it. And we'll do a broad intro on dementias because I think all of them may connect with neuroinflammation, and then we'll dive in more detail into some of the nuts and bolts. I will say as a preface, and I will try and remind you as we go through, you know, I know some of my slides are pretty busy and overwhelming, and they even are to me, and I just couldn't decide how to trim them yet, but I wanted to reflect, you know, where we know things, it's clear, and where complexities are and we don't, because the devil's in the details. And then I promise at the end, we'll make it clear and, you know, I think pared down to the essentials on the take home point. So it may get a little bit chaotic in the middle, but you know, I think even us in the field feel that way. Neuroinflammation is a complicated process, and I just wanted to have you experience that a bit as well, but we'll clear it up in the end. So with that, dementia, of course, is the word that we all use. In medicine and in neurology, it does have a specific definition or meaning for us, and that is specifically the loss of cognitive functioning, which affects typically more than one area of thinking, so that a person can no longer do what they would normally do. So this could be problems with memory and language enough that you can no longer do the job you used to do. It could be problems with multitasking and executive function and memory, so that you can no longer manage your household finances or do the grocery shopping and various combinations. And again, it's sufficient enough that your compensatory strategies, or the ways you try and make up for it, like taking little notes or using a calendar, those no longer work. So you just can't keep up with what you want to. Now, dementia, as I showed, is an umbrella term. And while we use it interchangeably sometimes with Alzheimer's disease, dementia can be caused by multiple different diseases. And here I've just listed the 5 most common. So Alzheimer's disease is the most common cause of dementia in adults, especially as we get older. It's the blue wedge of the pie here, making up about 60% at least of patients with dementia in terms of their cause of dementia. But Alzheimer's disease is not the only cause. And a second common cause here is vascular disease. So this would be just like you can get vascular disease affecting the blood vessels in the heart that lead to heart attacks and angina. You can get vascular disease that affects the brain. And so it leads to strokes, it leads to little bleeds and other damage to the brain cells that then lead to cognitive impairment. And we now know that Alzheimer's disease and vascular disease often co-occur, though not always, but certainly sometimes someone will be dealing with both. Another common cause of dementia as we get older is Lewy body disease. Lewy body disease is related to Parkinson's disease in that there is the same underlying molecular change. But in Lewy body disease, instead of having a few years of just tremors and motor symptoms, we see cognitive changes early on, which could be trouble with memory, with executive functioning, even with visual spatial functioning and processing visual information. Fourth on the list here, and the purple wedge of the pie, is frontotemporal dementia, which starts as it's named in the frontal lobes and the temporal lobes of the brain. And because it starts in those networks, it typically involves changes in personality or language early on, and memory is often spared. And although frontotemporal dementia is a relatively small wedge of the pie, if we look at younger adults, ages 45 to 65, frontotemporal dementia becomes the second most common cause of progressive dementia in that age group. And then finally, mixed dementia. So I mentioned before that Alzheimer's disease and vascular disease can commonly happen together in the same person, in the same brain. And the same is also true for Lewy body disease and Alzheimer's disease, or Lewy body disease and vascular disease, and maybe to a lesser extent, sometimes frontotemporal dementia. So we used to think of these as very discrete, separate diseases at the molecular level, at the level when we looked at brain tissue, but now we recognize that sometimes it's a mixed picture even there. So as of 2021 in Canada, and I'll give the caveats outside of Canada in a minute, we still make a diagnosis of dementia largely on clinical evaluation. And by that we mean taking a history from the patient and an informant, whether it's a family member or friend who spends a lot of time with the patient and has known the patient for a while, is essential. That tells us what kinds of trouble they're having, to what extent it's a change from their baseline abilities and level of functioning, and what else may be happening that could also affect that aspect of thinking. We then do a mental status and neurologic examination, looking for any clues as to which parts of the brain may be struggling based on the pattern of strengths and weaknesses on cognitive testing, and also on the neurologic exam, looking at strength, reflexes, vision, and eye movements, as they can hold clues for different disorders, in particular, some of the dementias that can involve Parkinsonism or symptoms that overlap with Parkinson's disease. We use brain imaging largely when we're doing a workup for dementia, largely to rule out other structural causes of cognitive trouble. So we might do an MRI if it's available, or if not, a CAT scan, a CT, to make sure that the cognitive changes aren't due to strokes, aren't due to a brain tumor or some other structural cause. Typically, in these gradually progressive syndromes, gradually progressive dementias, such as Alzheimer's disease, Lewy body disease, we won't see those things on the MRI. And if anything, we may see a little bit of shrinkage or atrophy. Sometimes, if the pattern on the MRI is pretty normal, if we're not seeing obvious shrinkage or atrophy in regions that would help support a diagnosis, and it's really not clear what's going on, then sometimes we'll order a functional scan, which in Ontario would be a SPECT scan. In other provinces or in the US, maybe a PET scan. The SPECT and PET scan give us a picture of the metabolism of the brain or the blood flow of the brain. And that really reflects whether different areas are working normally or not. So in a dementia, say, for example, Alzheimer's disease, if we look at the blood flow or the metabolism, we would typically see that the areas of the temporal lobe and the parietal lobe that Alzheimer's disease commonly affects will be less active and therefore requiring less blood flow than normal. So that on its own doesn't make a definitive diagnosis, but it can help to support a diagnosis if the imaging otherwise is not supportive. Now, depending on the nature of the presentation, if it was rapid in onset, if there are signs of inflammation on the brain imaging, certainly if there are any fevers or suspicion of infection, then we may do other blood tests, looking generally at blood cell count, liver function, kidney function, and sometimes spinal fluid tests, so after a lumbar puncture, to make sure that we don't see any detectable signs of infection or autoimmune response, though I'll give a caveat to that, that those tests are only so sensitive. So there we're looking for kind of the big infectious or obviously inflammatory diseases that we already know how to diagnose. We may do genetic testing if someone is presenting at quite a young age, typically well under 65 and more commonly in their 40s or early 50s. If they have a positive family history of another individual in their family having an early onset dementia, which is technically defined as before age 65, but really when we start to think about strong genetic risk, the pattern we would typically see is that it's one or more family members having the onset in their 50s, if not in their 40s. In gray here, I've put markers of amyloid and tau, and if you can see that it's faded out a bit, because right now clinically in Canada, those tests are not approved or covered by OHIP or Health Canada necessarily, although they are available in the US and they're available in Canada in some research protocols. And although we do have pretty good tests now to measure these molecules in the spinal fluid or on PET imaging, as I'll show you, it's not clear in the absence of an effective cure or treatment that the invasiveness of these tests or the cost merits it. And so that's why they've not been approved yet clinically in Canada. So with that approach in mind, many of you may have experienced something similar firsthand. But in the clinic, then we might consider that a patient comes in, we'll certainly think about the age, and I'll tell you why in a moment. In this case, we have a 78-year-old woman. She's brought into the clinic by her family who've noted concerns with her memory. They've noticed that seemed to start gradually. It wasn't as though one day her memory was perfect and the next day it was clearly bad, but gradually they noticed more and more trouble that was progressive. As one example, she may repeat herself several times in the same hour, questions or stories. She's increasingly misplacing objects around the home and they're ending up in really odd places. She's lived in the same place for about 30 years now, but for the first time, she's starting to get lost as she tries to drive to the grocery store or home from the bank. And they've noted that she seems more anxious than is typical for her. Such a presentation would be quite classic for the way that Alzheimer's disease usually presents. So as we're thinking about the history, what we're looking to hear are examples that would fit with a decline or a deficit in what we call episodic memory, that short-term memory, the recent memory of things that happened in the past hours, days, or weeks. In patients with Alzheimer's disease, because of the brain regions involved, it's quite common that early on, patients may have trouble navigating or feel disoriented along routes that ought to be familiar to them. They may have word finding trouble that's clearly more than normal for them and more than similar age peers. And they may have trouble with executive function, which is our kind of umbrella term for trouble with multi-step tasks that require planning and sequencing and organizing multiple steps to finish the task. The onset will be gradual and progressive as opposed to a stroke or a vascular lesion where suddenly that event happens typically over seconds to a minute and we see a stepwise drop off very quickly and then a plateau. In the neurodegenerative diseases, we typically see a more gradual onset, although we know there are exceptions to that, and often if someone is ill for another reason, we may see a bit of a downward step as well, and then more of a return to that more gradual decline afterwards, and we'll talk about that too. In Alzheimer's disease, kind of interestingly, typically our neurologic exam is normal. So as we test strength, reflexes, and coordination, most commonly patients have no trouble in those elements. When we think about our patient, this example, and risk factors for Alzheimer's disease, there are several that we ought to be aware of. The biggest one at this point is aging. And of course, there's not much that we can do about that. But we know as we get older as humans, an increasing percentage of us have the molecular changes of Alzheimer's disease in our brains to the point such that as we're about 85 years old, 50% of us will have Alzheimer's type changes in our brain. And that's not even counting, the additional number that may have vascular, Lewy body, etc. Genetic factors certainly play a role in Alzheimer's disease, and some of these are well understood and others really we're still trying to understand. The most common genetic risk factor for Alzheimer's disease is the one listed first, the ApoE4. ApoE4 is a risk gene, so on its own, it doesn't seem to cause Alzheimer's disease. We know people can have that gene and never develop the disease and live a long life. However, we know it increases the risk of developing Alzheimer's disease, so that if you carry one copy of that version of the gene, your chance of getting Alzheimer's disease is 3 times higher than if you don't have a copy of that. And if you carry 2 copies of this ApoE4 gene, then your risk of developing Alzheimer's disease is about 15 times higher than the average. Now, clinically, none of the guidelines suggest that we test for the ApoE4 gene in our patients. And the reason is just that it's a risk gene. So whether you carry it or not, it wouldn't make the diagnosis. The diagnosis would be made based on that other evaluation that we talked about on the last slide. Other genetic risks for Alzheimer's disease can fall into a category, many of them as autosomal dominant mutations. What that means is that you only need one copy of that mutated gene, and you almost certainly will develop signs of the disease if you carry that copy, so that it's usually affecting at least one person in every generation. Now, fortunately, these mutations are quite rare. The most common are listed here: APP, presenilin 1 and presenilin 2. And so we typically won't test for those in the clinic unless somebody has that family history of onset of Alzheimer's disease, again, usually well before age 60, and the patient themselves is presenting early too. Another interesting risk factor is low educational and/or occupational attainment, and we'll talk about that in a moment. Family history of dementia, which probably is related to the fact that there are other genes that may increase or decrease our risk of Alzheimer's disease. Some may be genes that increase our risk, but others might be protective. And all of those genes haven't yet been identified, nor has the modeling of how different combinations of those genes play out to our risk been figured out yet. History of head injury increases the risk not only of Alzheimer's disease, but of all the neurodegenerative dementias, as well as Parkinson's and ALS. Cardiovascular risk factors and probably diabetes, if not directly, because diabetes is a risk for cardiovascular disease, also increase the risk, and the female gender does as well, and that's even after we control for the fact that females on average will live to be older, and of course aging being that biggest risk factor. So I mentioned on the last slide that lower educational or occupational achievement is now recognized as a risk factor for dementia, and including Alzheimer's disease. And what the studies tell us so far is that it's not that low education causes the disease, but it's that you have less cognitive reserve in comparison, on average, to people who have done more schooling or more cognitively demanding jobs. So this concept of cognitive reserve is now talked about a lot in the literature and sometimes in the newspaper. And cognitive reserve typically is referring to the size of the brain, the number of neurons or brain cells that are in the brain, the synaptic density, which is the number of connections between the neurons, which are essentially our computing power. The more connections we have, usually the better. And the way these networks or connected neurons are set up determine a person's capacity to cope with a certain degree of brain pathology. So that this kind of anatomy of our brain, which we can increase the connections between our neurons, we can increase our synapses with learning and different activities. It's not as though that prevents Alzheimer's disease from starting in our brain, but what it does is that it, as it says here, allows our brain to have a reserve so that it can better cope with those diseases. So that someone who's had 20 years of education and someone who's had 8 years of education may have similar degree of Alzheimer's disease changes in the brain, but our patient who's got 8 years of education is more likely going to go show signs of that earlier stage of disease, whereas someone with higher years of education may have built more pathways and connections that can be called upon when Alzheimer's disease starts to affect a certain percentage. Now, in Alzheimer's disease, whether or not you may have high or low or intermediate cognitive reserve, over time, the most common finding, early finding, is shrinkage or atrophy in structures around the hippocampus. So the hippocampus is named for the seahorse shape. You have to use your imagination for that, of this structure deep in the brain. I think of the hippocampus as the save button of the brain. And the brain tissue, the cortex around it, is also a part of that key structure for saving new information that we learn. In early stage Alzheimer's disease, we'll start to see some atrophy or shrinkage of that hippocampus, which is in that medium gray here. And what's easier to see then is the secondary enlargement of the space next to the hippocampus, which is in black here. So on this side, we see some early mild hippocampal shrinkage. The other side looks pretty normal still. And as we go back to a more posterior part of the hippocampus here, it looks quite good. So this would be a scan in somebody who is perhaps not symptomatic yet, but is on the way to likely showing signs of Alzheimer's disease. As the disease progresses, the shrinkage of the hippocampus and the surrounding brain tissue in the temporal lobe advance so that we see further enlargement of that black space around the hippocampus, reflecting the smaller volumes there. And you can see here now, even in more dorsal or posterior parts of the brain, the bigger black space and the smaller hippocampus there. So we mentioned that Alzheimer's disease is the most common cause of neurodegenerative dementias and that aging is the biggest risk factor. Alzheimer's disease is defined ultimately only when we can see someone's brain tissue after they've died. And the defining feature are two molecular changes. One is the accumulation of a molecule called amyloid into these round, kind of fluffy plaques that are here in brown, if you can see my mouse. And the second component that defines Alzheimer's disease is the abnormal accumulation of another molecule called tau, T-A-U, in the neurons of the brain cells. And that's that darker, almost looks like a comet that you're seeing here with special staining. So biomarkers that can identify the amyloid and tau in tests that we can do while patients are still alive are here. And I mentioned they're available in some research studies, though not approved clinically yet in Canada. But there are PET scans where a contrast agent is given through an IV. That contrast agent can bind amyloid or tau. And in particular, it's well established for amyloid that patients with Alzheimer's disease have higher levels of amyloid that's demonstrated by this contrast agent in comparison to those that don't. We're starting to see similar patterns in the field in tau, although it's not quite as well characterized yet as the amyloid PET. I also mentioned that there are spinal fluid tests that can help to determine whether Alzheimer's disease is the underlying cause of someone's dementia or not. And quite excitingly, just in the past 2 years, there have been some breakthrough kind of landmark studies indicating that very likely we'll soon have blood-based tests that may help to rule in or rule out Alzheimer's disease. So this graph is from a study looking at blood samples from patients with different causes of dementia, all of which were verified either by autopsy or by spinal fluid molecular testing. And in comparison to the healthy controls or patients with mild cognitive impairment, the levels of the certain kind of tau in the blood were higher in patients with Alzheimer's disease, and they were higher even in comparison to many of the other dementias. These here were all different types of frontotemporal and related dementia. So it's not ready for prime time, not even in the US, but probably within the next few years, this will become a part of our clinical workup for these conditions. So with that background, what ultimately causes these diseases? So we talked a little bit about Alzheimer's disease, and one of those first genetic mutations that I mentioned that can cause this disease early on, running in families very strongly, was the amyloid precursor protein. And that mutation causes an abnormality in the processing of amyloid. So that became the dominant hypothesis for Alzheimer's disease, that because this single gene mutation could cause Alzheimer's disease, that amyloid must be the first key problematic step. And so most of our research in the field has focused on trying to block that abnormal accumulation of amyloid in the brain. In frontotemporal dementia, there was kind of a similar thought, just with a different molecule. So one of the first gene mutations that was identified that causes frontotemporal dementia was in this gene called MAPT. And mutations in MAPT were associated with the clumping up of this tau molecule in the brain. And so it was thought that that must be the primary cause, and treatment so far, or research on treatments, has in large part focused on ways to try and block that accumulation of tau. More recently, it was discovered that some patients with FTD don't have accumulations of tau, but instead they have abnormal patterns in their cells of a different molecule, one called TDP43. And we'll talk about that, but interestingly, TDP43 is associated with other mutations that cause FTD. And some of these mutations are in genes that do seem to be linked to immune system pathways, or possibly to inflammatory pathways. And then finally, for Parkinson's disease and Lewy body disease, although they're less commonly directly linked to a single gene mutation, they have in common the clumping up of a different molecule, this time called alpha-synuclein, in the cells. And so a lot of treatment research trying to stop the progression of these diseases has focused on targeting alpha-synuclein. On our pie graph before, when we were talking about the common causes of dementia, the non-neurodegenerative cause is vascular cognitive impairment. And again, these are strokes and bleeds in the brain that in accumulation or as they build up can cause cognitive impairment enough to make someone meet the criteria for dementia. These are little zoom-ins on areas of the brain on an MRI, just showing the different kinds of lesions in the brain that come under this umbrella term of vascular cognitive impairment. But those can be small little strokes, less than 2 centimeters in size, that we call lacunar strokes. They can be events that are not as clearly a stroke, but appear to be the silent closure of small blood vessels in the brain that lead to these white matter bright spots. This is a lacunar after it's gotten older, so we see a black hole where there's been loss of that brain tissue. Sometimes little strokes are thought to happen along the blood vessels of the brain so that we can see enlargement of the spaces around the blood vessels. And then finally, on certain sequences on MRI, we can see what we call little microbleeds that are kind of the size of a pinhead, but especially can accumulate most commonly in the setting of high blood pressure or in Alzheimer's disease. And that blood probably also disrupts thinking and leads to cognitive trouble. So with that in mind, although those have been really the dogmas of what causes those different diseases that lead to dementia, for a long time now, for several decades, if not more, there was always this kind of knowledge and hint that perhaps the immune system may be involved as well. So some of the first knowledge of this really comes from the established fact that when we look at brain tissue of people who have died from different neurodegenerative dementias, we see in the area of the brain that was affected higher numbers of immune cells. And these immune cells in the brain are called microglia. So on the left picture where the arrow is, you can hopefully faintly see an orange or rust-colored kind of spider-like or octopus-like shape. That's the microglia with all its little branches. Here, using a different staining, we can see in a patient who had frontotemporal dementia and had a granulin mutation that causes frontotemporal dementia, increased numbers of these microglia in the affected area of the brain. And the same is true, although perhaps to a somewhat lesser extent, in Alzheimer's disease. These findings, knowing that in the brain tissue there were increased numbers of these immune cells, led to the question, are these a part of the pathology? Are they a part of the problem and part of what causes the cells to die off? Or are they simply there in their role as kind of the recyclers, that one of their roles in the brain is to clear up the debris and things that shouldn't be there? And so it wasn't known, are these part of the cause or are these simply part of the effect of these dementias? This is one we'll come back to later. That isn't simple on its own, but it'll get even more complicated. So microglia, these immune cells in the brain, have functions. I've mentioned a few. Their presence, from the time our brains are formed as embryos, in the formation of our brains, they have important roles for the development and connection of the neurons. They have important roles in the nourishment and health of our young neurons. As we grow and our brain develops as children and teenagers and adolescents, they're involved in appropriate trimming back or synaptic pruning of the connections that we don't need to help the efficiency of our brain. They're also important for the immune response. So if there's an infection in the brain, these are the cells that activate to combat that infection. We know that they are triggered by the presence of the amyloid molecule and the presence of the alpha-synuclein molecule involved in Alzheimer's and Lewy body disease. And that as we age, these microglia become perhaps more activated, but perhaps less functional. But they have important roles both in fighting off infection and also in reducing inflammation. So these microglial cells have such a large number of functions that it's not easy to say when we see them in the brain tissue in dementia, what is their role there and is it a problem or not? With the finding that there were increased numbers of microglia in the brain of people with Alzheimer's and frontotemporal dementia, certainly people said, well, let's try to see if we can dampen down the response of those immune cells in the brain. Would that prevent Alzheimer's disease or delay the onset? So there were a number of clinical trials. These were, as you can see, in kind of the first decade of the 2000s, because there was a lot of enthusiasm. There are a lot of immunomodulatory medications already available. So there were lots of things that could be tried. This included large-scale clinical trials. Altogether, there were about over 12,000 patients who went through these studies, and unfortunately, none were promising. So they looked at naproxen and celecoxib. In a couple of different studies, they looked at low-dose aspirin in others. And most of these, there was no benefit. In the celecoxib group, they actually found increased rate of heart condition. So that became a warning for that medication. So with those negative clinical trials, the idea that the immune system was an active part of the problem in dementia got put a bit on the back burner, at least for several years, until there were some new genetic discoveries. And these genetic discoveries very strongly implicated the immune system and its role in having an increased risk of developing Alzheimer's disease and or frontotemporal dementia and possibly the other causes of dementia as well. So I mentioned ApoE4 as the most common risk gene for Alzheimer's disease. And it was discovered that this ApoE molecule is most commonly or largely expressed on the microglia, those inflammatory cells and related cells, astrocytes in the brain. Another gene, TREM2, which was found to be a risk factor for frontotemporal dementia, Parkinson's disease, ALS, and now Alzheimer's as well, is only expressed by microglial cells in the brain. Again, telling us that if these genes that affect these immune cells are related to increased or decreased risk, then they must have some role in the actual disease process. Other mutations causing frontotemporal dementia or other related conditions also were linked to have key roles in inflammation. So a question came up then, well, are there people who may have been exposed to medications that would modulate these kinds of immune responses? And have they been on them for a long enough time or at a key point? Maybe if you start these medications later in life, it's too late. But maybe if you are on them in midlife, maybe that would be effective. So they looked at patients with rheumatoid arthritis, because at that point, and probably still, it's one of the most common autoimmune diseases. It was well recognized for a long time, and there were immunosuppressive treatments that were used for rheumatoid arthritis. So epidemiologists then went back to say, well, in people who have rheumatoid arthritis, do we find that if they've been on treatment for a while, that their risk of Alzheimer's disease is lower? So those studies were done, and there was some suggestion that there could be a reduced risk in patients with rheumatoid arthritis who were taking medications that dampen down certain inflammatory molecules. Here, TNF-alpha, a molecule important for revving up inflammation, and not necessarily those that were taking other medications for rheumatoid arthritis that had different mechanisms. Beyond just Alzheimer's disease, certainly there, in the clinic, we get questions all the time, and we see, what about other triggers of inflammation and dementia? Is there a relationship? And certainly it seems like there probably is. So we know that people who have surgery, especially as they get older, into their 60s or older, quite a high percentage, anywhere from 25 to 40%, have delirium or cognitive deficits after surgery that may not clear for 3 months or so, or that happen within the first 3 months and may or may not ever clear back to baseline. We know that beyond surgery and general anesthesia, other kinds of medical events such as pneumonia or sepsis or diseases that put someone in the ICU, where there's a big inflammatory response throughout the brain, those kind of events and infections and inflammation double the rate of cognitive decline in the 6 months following the event. Now that's at the group level, so it's not going to be for every individual person, but it certainly tells us that some people are at high risk from those sorts of things. Probably there's a subset of people as well that do have a similar response if they've had cardiac surgery and gone on the bypass pump, and then again is thought perhaps to relate to the revving up of the inflammatory response in the body with that kind of surgery and procedure. And the question often comes up, if someone is going for surgery, well, what kind of anesthesia should I get? Should it be general or local? And a lot of studies have tried to look at this, and interestingly, there really aren't any clear associations between the type or duration of surgery or anesthesia and cognitive decline. There was one exception to that was especially the case in different non-human animal models, isoflurane, but that's really not used anymore. So for the anesthetics that are used now, it's not clear that any of them is particularly bad or better. And what it seems is that it's not necessarily just anesthesia, but it's the inflammatory response that comes with times when you need anesthesia, whether it's an inflammatory response induced by surgery because you're cutting through tissues, and the body's natural response to heal those wounds is to rev up the immune system, or if you've got a bad infection where that's happened. And to be a bit of Debbie Downer here, but not only does our body have to deal with those kinds of things as we age and have different medical events, but even independent of those events, we do see changes in the functioning of the immune system with aging, and most of those changes aren't that great. This is one of those complicated slides, and you don't need to think about the components here, but the take-home message is that our immune system has obviously a lot of critical functions, and it's important for fighting infection, And as we age, dysfunction of the immune system is one of the reasons why we become more susceptible to infections like pneumonia or COVID or others. As we age, dysfunction in the immune system is probably also linked to the increased risk of developing cancers, because our immune system is an important component for surveying ourselves for cancer and attacking cancer in early stages when the immune system can deal with it. As we think about connections between inflammation and dementia, another potential and interesting mediating factor can be the relationship with sleep. So we'll use Alzheimer's disease as an example, but this is true for most of the causes of dementia that I mentioned. So the sleep-wake cycle is progressively disturbed in Alzheimer's disease. And certainly as the disease goes on, the circadian rhythm can be so disturbed that people really don't have any discernible pattern of sleeping at night versus the day. We now understand that sleep deprivation may impair the clearance of that amyloid molecule that seems to be one of the first things that builds up in Alzheimer's disease. Or it could go the other way, that the early depositing of amyloid in our brain in those earliest stages of Alzheimer's disease does seem to localize around some of the sleep-related brain centers. And so it could be that that early deposition of amyloid is what's disrupting the sleep. In any case, it does seem like sleep disruption accelerates amyloid accumulation. So whichever way it starts, the problem then, as you might expect from those findings, that the risk of developing Alzheimer's disease is higher in people who have a history of sleep disturbance. So inflammation probably is one of the mediators of that relationship between sleep disturbance and Alzheimer's disease. And it's been found that if you sleep too little, so typically 5 hours or less a night, or too long on a repeated basis, both of those changes in sleep are associated with increased measures of inflammation when they've measured them in the blood. And this picture, again, one of those, we won't tease it all apart, but just telling us that if we've got disruption in our normal stages of sleep and sleep rhythms, that seems to then cause or be linked to this increase in inflammatory cytokines. Those are these small molecules in the blood that rev up inflammation in the immune system. And with that revving up then from the blood, we will get our microglial cells activated, and they may increase the amount of amyloid pathology that we see and reduce the amount of amyloid clearance that would normally be happening. So how do we tackle this problem, and how do we get to a way to test different therapies that might interfere with that cycle? So we and others have been quite interested in ways to visualize and measure neuroinflammation in the brain in patients who are living, not in only being able to look at the tissue after someone's passed away. So there's a type of brain scan called a PET scan, which can be used in conjunction with the administration of contrast agents. And these contrast agents are specially designed molecules that bind to specific molecules or parts of cells in the brain. So there are now several different contrast agents that can be used with PET imaging that can show us different aspects of the microglial cells and inflammation in the brain. Here in London, we have been producing and interested in a PET agent called 18-FEPA that binds to activated microglia and astrocytes in the brain. And so I'll give you an example. This is in a pretty rare cause of dementia, but it's one where mutations are known to affect the microglial cells. And what we can see here on the bottom panel in 2 patients who had this hereditary form of a dementia, we see that in comparison to normal controls, they show increased binding of the PET contrast agent especially in the frontal lobes and temporal lobes and regions where we know the disease occurs. And on the top panel, it's the MRI, just showing the white matter changes there in those regions. So on the bottom panel, this is representing increased activated microglia in the brains of these patients in comparison to age-matched healthy controls. So kind of a really exciting tool that will help us to understand when and how the immune system may be differing in different diseases. And then, of course, might be a useful measure to see if we try different treatments, what does it do to this inflammatory response? This is a lovely study that was done by another group just last year. And this was in patients who had MCI who progressed to Alzheimer's disease. And in the colored parts on these brain diagrams, basically they're showing that the amount of inflammation as measured by that PET scan was increasing over time in these patients who developed Alzheimer's disease, and was correlating quite well with the same areas of the brain where these patients were having the accumulation of tau. So it seems as though the microglial response and the accumulation of tau were linked. So with kind of those genetic discoveries, with this beginning of understanding of different roles of the microglia and the presence of altered inflammatory responses in the brain, new clinical trials are here and are coming, looking at ways to modulate the immune response to see if it may prevent the onset of dementias or at least to slow their progression. So this is just a schematic, but this blue cell on the left would be a neuron. In the example of Alzheimer's disease, there would be tau tangles and these amyloid aggregates that are toxic to the neuron. And it perhaps is the microglia that is mediating the buildup of these two and the toxicity. So these trials are using different ways to try and interfere or slow down or quiet down that microglial response. Some are with antibody infusions, but others will be small oral molecules, and even in some cases, viruses that would be injected that have been modified. So those trials, some have started already. A great resource if you're looking at what's running right now anywhere in North America is clinicaltrials.gov. They're very selective at this point of where they're running and what patients are eligible, but certainly if you're interested, it's worth checking out. But I just wanted to spend the last part of the talk kind of thinking about, well, you know, what can we do in the meantime otherwise outside of those trials? And certainly for those of us maybe doing okay so far, but of course we're all at risk. What can we do to feel that we've reduced our risk as much as possible or advised our family members of the same? Last year in the Lancet, one of the preeminent medical journals, there was a landmark publication highlighting 9 risk factors that have been associated with the development of dementia that are, in theory, preventable or reversible or modifiable. We'll go through these and I'll remind you at the end, but I'll just say the one caveat to this, although this is exciting because we think, okay, you could do something about these and reduce the risk of dementia. The one caveat is that these have all been studies that are looking at associations, but they can't prove cause and effect. So it could be that some of these risk factors are really proxies or indicators of something else going on and aren't the actual problem themselves. But we'll go through them nonetheless, because for now, it's kind of the best direction that we've got for practical action. So in the course of the lifespan, these risk factors seem to be important at different points. Early in the life, those who had less education earlier on, as we talked about before, not always, but on average, have less cognitive reserve, and so are more likely to show symptoms of a dementia earlier than they would if they had had more education and job kind of cognitive stimulation. So for sure, that tells us that we should all pursue education, to the extent that we can, and certainly to help our kids and grandkids do the same. When we get to midlife, the key risk factors appear to be hearing loss, traumatic brain injury, including concussion, hypertension, increased alcohol use, which was defined as more than 21 units of alcohol a week, and obesity. As we come later in life, smoking, depression, social isolation, physical inactivity, air pollution, and diabetes appear to be risk factors. Now, again, some of these may be signs the dementia is coming and not necessarily risks in and of themselves. When they try to control for those factors, it still seems these are probably independent risk factors, but again, we don't know for sure. When they sum all of these up, it comes to saying that about 40% of dementia, if reducing these risk factors reduces the risk they seem to contribute to dementia, then we could modify as much as 40% of dementia worldwide, which is quite exciting. Now, a lot of that modification is going to be due to reduction of vascular dementia or vascular cognitive impairment, because that's where some of the strongest association with these risk factors are. Certainly smoking, obesity, hypertension, and diabetes increase the disease of our blood vessels everywhere in the body, including the brain. And if we treat those early enough, then we have less strokes, we have less brain bleeds, and we have less dementia. So from those risk factors, you could imagine the take-homes, but they're here across the course of the lifespan, and including in midlife, when maybe it doesn't seem like such a big deal. We really now think we need to target good blood pressure control. So that's a systolic or top number of 130 or less, starting from the age of 40 years and on. We saw hearing loss was a risk, so certainly to encourage hearing aids in midlife and early on, and try to reduce causes of hearing loss, such as excessive noise exposure. Reducing exposure to air pollution and to secondhand tobacco smoke. Preventing head injury, wearing helmets, and being conscious that concussions, even though it might seem reversible at the time, may have longer lasting effects down the road. Limiting alcohol use, and certainly avoiding smoking or stopping smoking. And of course, smoking, high blood pressure, diabetes will reduce risk of heart attack and stroke and a lot of other diseases as well if we can control them. Making sure all children have primary and secondary education, reducing diabetes, as we've mentioned, and associated obesity and diabetes. And then finally, thinking about making sure that we think about this across a broader range of populations than have necessarily typically been those that have been studied in research, and encouraging environments where physical activity is more the norm than it is in a lot of our culture right now. So I promise the take-home points are just 2 slides here of take-home points, because I know this was a lot of information and a lot of things on the slides. But what I hope you'd come away with is that recent genetic discoveries really strongly support that dysfunction of the immune system of the brain is probably a factor in the neurodegenerative dementias. It seems now across a lot of studies and a lot of types that conditions or events that cause inflammation in the body, whether it's surgery, an infection, possibly an autoimmune disease, may also, at least in some people, increase neuroinflammation, and that in some people that may accelerate their neurodegenerative disease. And then finally here, understanding the role of those immune cells in the brain, the microglia, especially as our brains age, seems to have promise in identifying new treatment approaches for Alzheimer's disease and the other dementias. Our action items then, can be really summarized 3 ways. Stay physically, cognitively, and socially active at all stages of life to stimulate those networks in the brain. to stay mobile and exercising. It seems aerobic exercise may be a bit better than resistance training or weight training for the brain, although of course resistance training is good for bone density, etc. But exercising at least 30 minutes a day, at least 3 times a week, and more if you can. Our best evidence for eating healthy is the Mediterranean diet, which is a diet higher in fishes, fruits, vegetables, legumes, and lower in red meats and saturated fats. Trying to get the optimal amount of sleep, not too little, not too much. So for most people, it looks like 7 to 8 hours is the sweet spot there for brain health. Because of the inflammatory response that even elective surgery can cause, really, only having surgeries that are necessary may reduce your risk of unnecessary inflammatory experiences that could have effects on the brain down the road. And of course, trying to avoid concussions. So a lot of collaborators specifically on our work with neuroinflammation in London, and a lot of the work I presented, certainly hopefully you saw on the bottom of the slides, was done by other groups across the world as well. So I'll stop there, and I think we still got quite a bit of time for questions. I'll turn it back over to you, Jeanette.
Yes, thank you, Dr. Finger. That was fascinating. That was very interesting. Some of the things that really stood out to me was, for one thing, when you were talking about the testing, the serum testing, and the potential that we have coming up soon for, possible blood testing. What a difference for diagnosis, what a difference for earlier diagnosis that may make, and, for the lives of so many people with dementia. So it's so good to see the progress on that.
Yeah, I agree. I think that's one of the most exciting things, that's come in the past year or two, and will probably be very exciting in the next few years for all the reasons you've said. And economically, it's much easier on the healthcare system to pay for a blood draw than a PET scan or a lumbar puncture. So that really will hopefully open up better care options.
That's wonderful. Increased opportunities for testing. That's wonderful. If anybody has questions, you can put them into the chat box below. We had one question that came in before, and you've already made some of the references to it, but I did want to read it because it echoed some of the other things that I know some people have said out in the community as well. So if somebody has a family history of an inflammatory disease, such as alopecia was the example, and Alzheimer's disease, is there evidence that a pre-existing autoimmune disease will be a factor in contributing to future dementia? Does it increase with each factor, I guess maybe is one way to put that.
Yeah, it's a great question. So some forms of alopecia, and I think the one in this question was alopecia areata. So alopecia is our jargon medical term for hair loss, but alopecia areata is an autoimmune cause of hair loss. So it's pretty rare. It's not our more typical kind of thinning as we get older, but quite prominent hair loss in different places. And it's known to be autoimmune, but exactly what part of the immune system is dysfunctional causing it hasn't been worked out. I did look when you sent that question, so I didn't see anything specific to alopecia areata, but what I can say more broadly on autoimmune diseases in general, so if we look at lupus, even psoriasis is a more common autoimmune skin condition than on its own isn't always that severe, but somewhat prevalent, and rheumatoid arthritis. So there does seem to be a higher rate of dementia in people who have a history of those kinds of autoimmune conditions. When they look further, and some of the most recent studies came out a couple of years ago on this from the UK, it seemed like those autoimmune conditions were associated with just about a 6% increased rate of having Alzheimer's disease compared to those people who didn't have them. but that there was a higher risk of vascular disease, so maybe 14% or so higher rate of vascular dementia. So what that's probably telling us is that those autoimmune conditions probably have effects on the vascular system, on the blood vessels and their health, and that with those, you're more likely then to have narrowing or closure of the blood vessels or strokes that then give rise to those vascular events in the brain that cause vascular dementia. In some autoimmune diseases, that's pretty well, known already. Certainly in lupus, there's an increased rate of blood clots and strokes. But in psoriasis, I don't think that was really recognized to be the case. So it's a good clue that there are things there to be worked out, probably a small increased risk of Alzheimer's disease, and then a bit of a bigger risk for vascular dementia.
Okay, thank you. We have another question here. Do you see a relationship between Lyme disease and MCI dementia?
So not specifically, but part of that is just the terms and the semantics. So mild cognitive impairment, I didn't define that, but mild cognitive impairment is kind of an umbrella term, and it's got a functional meaning. It means that you're having a little bit of trouble, usually in just one area of thinking. So just in memory, or just in language, or just in visual, spatial stuff. But that you're only a little bit below other people your age, and you're still able to compensate and do what you would normally do. So as you can imagine, kind of like dementia, MCI could be caused by lots of different things. When we use it in the medical literature and in research, we're usually talking about MCI that's sort of that first stage of Alzheimer's disease, where patients start to have a little bit of memory trouble, but with notes and calendars, they're able to compensate. Technically, someone could present with some mild cognitive trouble, and then in the workup that you would do, which would be the same workup as you would for someone with more significant memory problems, you would probably get brain imaging. And there, in the setting of Lyme disease, most commonly, you would see obvious lesions, changes in the white matter of the brain that would look inflammatory, and that would typically then trigger that more involved workup I mentioned with blood tests for infections, including Lyme antibodies, with lumbar punctures, looking at that as well. So I guess that would be how we would disentangle those.
Those two, okay. Thank you. We have another question here. Once diagnosed, so I think that means with dementia, what types of drugs would be prescribed, and what would those drugs do? So perhaps speaking to the medications that are commonly recommended for dementia.
Absolutely, yeah. So, probably as everyone on the call knows, right now we don't have treatments that slow or stop or cure any of these dementias, whether Alzheimer's, Lewy body, etc. So the treatments that we do have and that are approved for use now are what we call symptomatic treatments. So they're not tackling the underlying amyloid or tau or inflammation, if that's the case, but they're trying to deal with the consequences as best we can. So for Alzheimer's disease and also for Lewy body disease, if patients are having some memory trouble or trouble with attention and concentration, the most commonly used medications that are approved for those conditions increase a neurotransmitter in the brain that's really important for attention and concentration, and therefore it can make people's thinking just a little sharper, their memory just a little better. The most common one of those medications is called donepezil, or the trade name is called Aricept. There are two others, galantamine and rivastigmine. They've been around a long time now, so they're all available in generic. They're sometimes helpful. They're not miracle medications. I would say maybe 30–40% of patients who try them see some benefit, but not everybody will. One other class of approved medications for Alzheimer's disease in particular here in Canada is called Mementine. It's approved only for moderate and severe stages of Alzheimer's disease, and it is approved to try and help with some of the behavioral symptoms of Alzheimer's disease, such as agitation, extreme anxiety. It's usually well tolerated, and again, not helpful for everyone, but often worth a try.
Okay. Thank you. Okay, we have a couple more questions here. One with, in regard to autoimmune disease, have you seen a correlation between thyroid disorders and Alzheimer's disease? Does a thyroid condition, if it's not properly treated or controlled, affect cognitive function, or predispose to Alzheimer's disease?
Yeah, great, absolutely. And I appreciate the question because thyroid disease is so common. Mm-hmm. So we do know that one of the more common causes of thyroid disease and hypothyroidism in particular, where your thyroid hormone levels get unusually low, do have an autoimmune component. It's called a Hashimoto's thyroid disease or thyroiditis. And so in some of those epidemiologic studies that I mentioned, both in Alzheimer's disease and also in FTD, it does seem that autoimmune thyroid disease may be one of those conditions that is linked to a slightly higher risk of developing Alzheimer's disease or dementia. Again, it's certainly, that doesn't mean that everyone that's got thyroid disease is going to develop it. So we're talking about a few percentage points here, but it's a clue maybe. Independent of that autoimmune possible link, certainly on its own, if your thyroid hormone levels are too low or too high, both of those can impair cognition. So certainly if your thyroid levels are too low, you can be fatigued, low energy, confused. And so that is a routine screening, and anyone's coming in with a new cognitive complaint is to measure their high thyroid hormone levels for that reason, because those can be easily treated.
Thank you. Here's another question. Are there other therapies recommended for people struggling with dementia? So exercise, etc.
Yeah, so a great question. I'll say of the things that I presented and sort of those lifestyle modifications, to be honest, it looks like those kinds of things, if they're going to be helpful, it's going to need to be well before the onset of Alzheimer's disease. So in that early life, midlife stage, carrying through those healthy practices after midlife is probably the way that they'll reduce the risk of dementia if they're going to. So we have less evidence that once someone has Alzheimer's disease, that those kinds of lifestyle changes would make a difference. That said, we do have kind of a different body of literature showing us that patients with dementia, whether from Alzheimer's or one of the other causes, do better and can stay at home longer if they are stimulated physically, cognitively, and socially. So that's what we try to recommend, that day programs that are offered in lots of places across Southwest Ontario are great for that, because they may go even if it's once a week, or before COVID, maybe a bit more than that. You've got a social group, so you're socializing, you have the emotional experiences and the communication that comes with that. They will build in cognitive kinds of tasks that don't have to be, feeling like homework, but are just ways that you are thinking that you might not if you're sitting at home, in front of the TV or just with the word search. And then physical too. So, just like the body, the brain is kind of use it or lose it. So we want patients to keep walking, to keep their mobility and balance as tuned as we can. And the same way we exercise those language and other cognitive networks with a variety of activities.
Thank you. Yeah, staying physically and cognitively engaged is so important. And like you said, it aids in independence too in such a strong way. Okay, we have many other questions now. And we have one hand up, which I will get to after this next question. So with the stigma around mental health in older generations, there can be a resistance to be assessed for mental or cognitive or brain health. It can be challenging to convince someone to discuss these issues with their doctors. Are medical professionals able to diagnose Alzheimer's easily? Are there many scans, tests required? So maybe, speaking to that diagnosis process.
Yeah, absolutely. I mean, I think on a personal level, we can all relate to that, right? If we don't want to probably acknowledge if our memory is worse than it ought to be, and who wants to then go and have somebody prove that to them. So I think patients being hesitant to come in is more common than not. And often it's very helpful if they have that longer relationship with their family physician or nurse practitioner, so that it can be brought up in a place they're familiar, and someone who knows them then too can see to what extent is this a change and how might it relate to their other health issues. So that's ideally the best starting point. That primary care physician, family doctor, nurse practitioner often can make a diagnosis of Alzheimer's disease if it's presenting in a pretty classic way. So if it's gradual onset but progression of trouble with short-term memory, other things are physically okay, and they would need typically at least a CAT scan, so one brain image, whether CAT scan or MRI, to rule out stroke and other causes. Then often they can make a diagnosis of Alzheimer's disease that's pretty reliable. Where it gets tricky and where the referral to the specialist, like the neurologist, is often important is if patients are younger, and so they may present with some atypical features, or their MRI may look perfectly normal, or if there are other comorbidities, autoimmune disease or other things that could impair cognition. So if they come to the specialist, usually that's because they need a little more extensive cognitive testing, usually at least a half an hour, an hour or so, although we may not need any other imaging. The blood tests aren't here, but I think one day, it'll be that we might not all get screened, but maybe once you start to have some concerns or you reach a certain age, then you would have your screening blood test. And depending on the results, ideally then if there are these treatments that can modify it, then you get put on one of those pathways. But yeah, I think it's tricky, and adding to that trouble is if someone is having cognitive trouble and it's significant and they disclose it to their physician, physicians legally do have to report that to the Ministry of Transportation if there is a diagnosis of a dementia, and so that can further complicate that trust and relationship of someone who didn't want to come in the first place. So I don't think we've perfected the way to approach that.
Okay, thank you. It can be a difficult conversation to bring up for sure. We have somebody with their hand up, so just so you know, if you have your hand up, you can also enter it into the chat button. If I can click allow you to talk, and then you will be on the screen though, just as long as you know that. Okay. Okay. Okay, would you like to talk? Okay, we will wait there and see if he would like to talk at some point. I think we have another question on here. And this is a question. about type 3 diabetes. I remember when I first started working at the Alzheimer's Society of Huron County, I used to hear this question as well. I have heard of a type 3 diabetes related to insulin and cognition and diabetes and Alzheimer's. Can you briefly touch a bit more on the connection of diabetes and that connection? So it's sort of a two-part question here. And the second part is, are there some steps that someone with type 1 diabetes can do to support their brain function?
Yeah. So I'll try. I would say, if you know the term type 3 diabetes, it's likely you probably are better versed in that than I am. I think type 3 diabetes is kind of a term that might represent a hypothesis that's trying to link together some of this literature to say that it seems there are patterns that relate insulin resistance in the brain to Alzheimer's disease or to the acceleration of the pathology of Alzheimer's disease. So in type 2 diabetes, our bodies are still making enough insulin, but our cells become resistant to insulin. And so you get this overproduction of insulin. So it's, I think, looking at that concept that we know happens in the body and saying perhaps that is what's happening in the brain and part of the driving force for this risk factor, potential link of diabetes and Alzheimer's disease, at least later life diabetes. Beyond that, just out of my own ignorance, I can't say much more about it. So I apologize. I don't know where that's headed just yet. Although I think there's a lot of research looking, an increasing number of clinical trials looking at medications used for diabetes, so oral hypoglycemic agents, to see whether or not it delays the onset of Alzheimer's disease or slows progression. And I think for most of those, they're just kind of starting out. So we don't have results of the bigger clinical trials yet, but they're coming. And I think there's one coming to London soon too. Type 1 diabetes. So they're, the biggest, as an autoimmune form of diabetes, the biggest risk for that is going to be the vascular disease that type 1 diabetes is a risk factor for and associated with. So they're, just as one would just really trying to reduce those vascular risk factors by having the best control of type 1 diabetes that you can, and then watching carefully and treating for complications like high blood pressure, high cholesterol, of course, not smoking, which would exacerbate that vascular disease as well.
Absolutely. Okay, thank you. Now, the one person with the hand up, I think if you have a question, you can enter it in the chat box or you can send it to me later. We seem to have some trouble there connecting with that. And I believe that is all of the questions that we have. And I just want to thank you again. It's always so good to hear the latest research to, a lot of times when we are talking out in the public, we're talking about the importance of, like you mentioned, sleep. You mentioned hearing problems, and we hear about these things. It's so good to hear that the research that is behind it, emphasizing what those healthy choices can do and how important it is to take care of those issues as best as you can. I know sleep, I use that as an example. That can be a hard thing for a lot of people, but it all makes such a big difference to brain health. I do see, oh, okay. Many people are saying, thank you so much for being here with us tonight. We really appreciate it. It's so nice for us to hear somebody live and in person and being able to answer some of those important questions that we have. So I just want to thank you again. Thank you so much. We do have a gift basket waiting for you at the Alzheimer's Society of London office, so you don't have to make the trek up to Huron County. We put in, some special, yeah, some Huron County items that you can enjoy.
Oh, that's kind. Thank you.
Yes.
I greatly appreciate, as I mentioned, you probably, sorry that you asked me with so many complicated slides and things, but hopefully there were some points that made sense. And certainly the questions, just reflect the high level of knowledge that the audience has with these topics. So I really appreciate the engagement.
Okay. Well, thank you so much. Um, Before we sign off, I am going to launch a poll. It just helps us know, who was here, how you heard about our event. Thank you for joining us. Thank you from all of us at the Alzheimer's Society of Huron County. If you have any other questions, you can certainly email me or anybody else at the Alzheimer's Society. You can go to our website, alzheimer.ca/Huron County. We have lots of information. We have some more education events coming up. If you click on our Education Hour tab, you will see some of those. And I believe we have a golf tournament coming up, a Halloween golf tournament as well. So if you're interested in any of those, please check out our website, alzheimer.ca/Huron County. So again, thank you, Dr. Finger, and thank you everybody else for attending.